Stephanie Bell-Flint joins us now, and we're talking about mammograms. And if you have questions, please send them to the doctors at WLBT.com.
Thank you, Maggie. Joining us is Dr. James Burkhalter. He is with the Center for Breast Health at Baptist Medical Center. Thank you so much for joining us. October is Breast Cancer Awareness Month, so we can't get the messages out there enough this month because it is a great opportunity to do so. What do women need to know most?
The importance of early detection with regard to breast cancer, and there are different aspects to that. Physical examination, most of us still think, is very critical, but imaging is at the forefront. Mammography is the keystone there to early detection.
Why is imaging, or the mammography, why is that so important to women?
Your prognosis, your outcome, your survivability, or the options for treatment that are available to you really depend on the size of the disease at time of diagnosis. So you don't want to wait until you feel a large lump. You hope to pick it up before it's felt at all. And that's where mammography comes in. Can pick up tumors down in the millimeter size range, centimeters, a ½ inch. So if you have a tumor found on mammography that size, it's probably one that was picked up on screening, not on physical exam.
So when we see these pictures of mammographies on our newscasts, to us it looks like a picture of the Milky Way galaxy. Mm-hmm. You know, it's hard to see. So what are you looking for there as a radiologist?
Okay. The easier mammogram to read is one of the fatty replaced breast. It looks like a dark sky.
Okay.
So you're looking for stars, calcifications that don't belong there, or you're looking for clouds, densities that weren't there before. The dense breast, especially in younger women, is a harder one to read on the mammogram. So some other screening studies can provide additional sensitivity in those particular cases. But for us, speaking as a radiologist, we always say our best friend are old exams, because now you have a photographic record of how the breast looked 4 years ago, 3 years ago, and you can pick up subtle changes if you have those available.
So you do want those subtle changes if they're happening. You can monitor that.
Right. That increases your chance of picking that up. At the first time mammogram, you may get some additional imaging done because you don't have that prior record to be able to relate back to.
Now, I know radiologists are also very important when it comes to mammograms for women who have cysts versus it being cancer. And so if you're a woman who is prone to have cysts, the radiologist becomes a real good friend.
That's right. And that individual will also likely, repeatedly, with annual exams, get additional studies. So they don't need to get real anxious if they know they form cysts. Ultrasound will usually help sort those out. Most of the time that's all it's going to be. But the first time they're told you have something we need to look at further, they'll be real anxious, and that's just normal.
Okay, getting some questions here. I'm 77 years old. I have had 2 benign lumps removed in one of my breasts in the 1980s. The breast surgeon still has me coming in for an exam after my mammogram every year. So at this point, due to a severe back problem, I'm unable to lie on the exam table. Do I really need to continue going?
All right, now she must be describing lying on the exam table for her surgeon, because your mammogram is always done
standing
or sitting if you're in a wheelchair.
Right.
So it really would be a question that may be better directed to the surgeon, but the physical exam still plays an important role, and that can be done without the lady lying down. The reason the recumbent laying down position is so much better, gravity tends to spread the breast tissue more evenly across the chest. It makes it easier to palpate and pick up a lump that may be deep.
I think it's important to also mention that men get breast cancer as well. Tell us about that.
They do. Certainly there's genetics involved on occasion, but a man can get a lump. He can get a breast cancer. More common in men is a condition called gynecomastia, which is a result of change in testosterone hormone levels, so that the breast tissue behind the nipple starts to proliferate a little, to grow a little, and it can be sensitive and it can feel like a lump that wasn't there before. That can be investigated and then usually dealt with too.
Tell us about a breast biopsy, and it sounds like it would be frightening. What happens when you have to have that breast biopsy?
Nowadays most breast biopsies are outpatient procedures without going to surgery, without an anesthesiologist, done under local anesthesia. If it's an ultrasound guided biopsy, the lady is lying on her back so that you can get to the front of the breast. You anesthetize, numb the skin, make a little tiny incision so the larger biopsy needle can go in. And on the ultrasound screen, you can watch the needle approach the lesion, and then it goes and takes a little bite of tissue. And you usually do it 3 or 4 times, so pathologists have enough to look at under the microscope. The other form of biopsy is also a needle technique, but it's using a mammogram as your eyes into the breast. And for that, most often the lady is lying on her stomach on a special exam table that has an opening that the breast can be suspended through the opening and then dealt with compression, like at the time of a mammogram, and you hone in on what you're looking for. Same numbing, same little incision, and the needle goes in and shaves out bits and pieces of tissue.
Dr. Burkhalter, do women who are over a certain age, you know, I think it's a certain age once you get in your mid-70s or something, it's not recommended unless you have a history of breast cancer that you get mammograms anymore. What is the guideline there? It's confusing to me. And I think it's confusing.
Says very quickly.
Very quickly.
Okay. The benefit of screening is to pick up early, and most folks say that unless the patient has a life expectancy of 5 to 7 more years to continue screening, they're not going to get the benefits. But then there are other factors involved. There are other comorbid conditions. If they have other malignancies and all, then there may not be much benefit from screening in those circumstances.
All right. Dr. James Burkhalter, thank you so much from the Breast Health Center at Baptist. Thank you so much. And for the latest health news, log on to our website, WLBT.com, and click on Medical Matters.